Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. We're delighted that you're joining us today for an event focused on perinatal mental health, the topic of our October 2021 issue. We're really excited to be able to present the material and this event. It's a perfect fit for Health Affairs. It covers an important topic. We advance the scholarship where new scholarship is desperately needed, and it's right in the thick of the policy debate, which is right where we like to be. Now, rather than give a substantive introduction to the topic, in a moment, I'll turn the microphone over to Jennifer Moore, who is our theme issue advisor. After her introduction, you'll hear from Congresswoman Lauren Underwood and Chief Population Health Officer at CMS, Ellen Marie Whalen. After their remarks, we'll have a brief discussion, and we'll then turn to presentations of 5 of the papers that appear in the issue. Now, for those of you who are watching us live, you can submit questions at any time in the form below the video window on your screen. I'll do my best to weave as many of them in as possible, but I can't promise that I'll get to all of them. We are recording the event. We'll post the video on the event page within a couple of days, and the speaker slides are already posted there. As we start, I also want to acknowledge the financial support we received for this issue from the California Healthcare Foundation, the Perigee Fund, and the Zoma Foundation. The issue and this event simply would not have been possible without their support. And now it's my pleasure to introduce to you our issue advisor, who is also co-author of a number of papers in the issue. Jennifer Moore, an elected fellow of the American Academy of Nursing, is the founding executive director of the Institute for Medicaid Innovation and an assistant research professor at the University of Michigan's Medical School's Department of Obstetrics and Gynecology. I'll turn it over to you, Jennifer.
Thank you, Alan, and Health Affairs for the opportunity to serve as the theme advisor. It is with great appreciation that I also express my gratitude to the funders of this special theme issue, the California Healthcare Foundation, Zoma Foundation, and Perigee Fund. Through their generous support and commitment to pregnant individuals and the impact of perinatal mental health on children and families, this is the first time in the 40-year history of Health Affairs in which an issue has been dedicated to a topic that impacts individuals with the capacity to give birth. It is my hope that this is not the last issue and that we do not have to wait another 40 years. And finally, I want to thank everyone who submitted an abstract for the theme issue. It gives me great hope that the body of scientific knowledge on this important topic is growing and gaining the attention it deserves. Your work is valued and appreciated by all. If it wasn't for the page limits of the journal, we would include every submission. Despite its high burden of morbidity, mortality, and economic cost, perinatal mental illness is poorly addressed by the U.S. healthcare system. 1 in 5 pregnant or postpartum individuals has a diagnosed mood or anxiety disorder with increased vulnerabilities for depression, pharmacotherapy discontinuation, addiction recurrence, and overdose death. Perinatal mental illnesses contribute to adverse outcomes during pregnancy and postpartum, including pregnancy-related morbidity and mortality. As we know, the U.S. has one of the highest rates of maternal mortality, with glaring disparities for Black and Indigenous people. Perinatal anxiety in the last trimester of pregnancy can increase risk for preeclampsia, cesarean birth, and neonatal intensive care admissions. The burden of perinatal mental illness is not limited either to the pregnant individual or to the time immediately surrounding pregnancy. Perinatal depression can lead to fetal growth restriction and postnatal cognitive and emotional complications, including infant attachment barriers and poor cognition. Both at and well after childbirth, perinatal mental illness generally can lead to psychological and developmental disturbances in infants, children, and adolescents, preterm birth, and low birth weight. Untreated perinatal mental health conditions that occur during pregnancy and the first 5 years of a child's life carry a societal burden of $14 billion per year in the US. That's a B for billion, and that's an underestimate. Early detection, prevention, and effective treatment could reduce the effects of perinatal mental illness on childbearing people, infants, and their families. Nonetheless, societal and healthcare system features present obstacles. Persistent cumulative deficits and barriers include lack of screening, limited clinician follow-up and coordinated care after screening, barriers to access to care, stigma, shame, judgment, and blame, all of which impede the pursuit of preventive or psychiatric services. Even when people receive a positive screening test or diagnosis, the landscape remains difficult. High rates of attrition persist when patients are referred outside of their preferred care system. Although promising collaborative care models that integrate mental health services into perinatal clinics exist, these effective options remain unavailable to most pregnant and postpartum individuals. Availability is limited by the lack of billing codes for same-day or multi-clinician visits and lack of co-located services to care to support physical and behavioral health integration. Furthermore, racial and ethnic inequalities persist in the identification of illness and its treatment. Black individuals with postpartum depression have lower odds of initiating treatment, following up with treatment, and refilling antidepressant medications. As noted by our co-author, Dr. Monica McLemore, in our overview paper, in the absence of research documenting the causes of inequities, listening to the voices of Black communities to take into account their lived experiences become critically important. Barriers to appropriate identification and treatment of perinatal mental illnesses include differential access to services based on the payer, fragmented and siloed care delivery systems, the lack of a workforce that is culturally and racially concordant with their patients, and the persistent effects of systemic racism and sexism. Today, I'm joined by an esteemed group of colleagues presenting their research findings. They will share more nuanced details that elevate these issues and challenges. In addition to their work, I also want to make you aware of the other exceptional papers that were included in the theme issue. For instance, Adrian Griffith and authors describe the current federal and state policy efforts. Melissa Zokowski and colleagues found that cesarean section rates are higher on average for those with perinatal mood and anxiety disorders compared to those without. Sarah Cornfield and colleagues studied mental health and resilience among individuals who were pregnant during the early lockdown phase of the COVID pandemic. Through interviews, Kay Matthews and co-authors identified key pathways to advance equitable and anti-racist perinatal mental health care, such as educating and training practitioners, investing in the Black mental health workforce, investing in Black-led community-based organizations, valuing, honoring, and investing in community and traditional healing practices, and promoting integrated care and shared decision-making. It was found by Clare Mergerson and colleagues that Medicaid expansion was associated with a 16% decrease in self-reported pre-pregnancy depression. These articles, along with many more, can be found in the October issue. As we hear from the panelists today, I want to encourage everyone to consider 6 policy opportunities that we can take action to address perinatal mental health. Next slide. With the guidance of my co-authors, Drs. Monica McLemore, Nadia Glenn, and Kara Zivin, we present tangible opportunities in our overview paper that would, if implemented, have a tremendous impact on addressing longstanding issues and advance perinatal mental health. First, expansion of Medicaid coverage. Approximately 4 in 10 people with Medicaid coverage do not make a postpartum visit, forcing them to self-manage postpartum depression. Extending Medicaid through at least 12 months with comprehensive perinatal care would ensure access to services, including prevention and treatment for postpartum depression and chronic conditions that are essential for the well-being of people and their infants. Second, support co-location of services. People generally receive postpartum care from clinicians in locations and health systems that are different from where their infants receive care. Co-locating care to support same-day, same-location appointments for the postpartum individual and infant reduces barriers to accessing care. It also facilitates physical and behavioral health integration, including joint assessment and management of depression and overall health during the postpartum period. Third, cover evidence-based, community-centered models of care. Community-based maternity care professionals such as doulas provide valuable services including home visiting during and after pregnancy, labor support, and encouragement of autonomy and empowerment. During home visits, they can identify signs of maternal depression, address interconnected parent and child needs, and provide culturally congruent support in the home, which has been shown to increase breastfeeding rates and patient satisfaction and reduce perinatal health disparities and overall healthcare cost. Fourth, enhance telehealth policies post-pandemic. The COVID-19 pandemic has demonstrated that access to telehealth has offered a safer and more convenient method for accessing healthcare services. In March 2020, CMS created new flexibilities that adapted and expanded telehealth, including behavioral health services, thus opening up an opportunity for payers to maximize the potential benefits of telehealth services. The time-limited pandemic policies allowed clinicians and Medicaid health plans to shift in-person care visits to telehealth, thereby supporting access to essential care. Fifth, enhanced data, research, and accountability. The development and use of perinatal mental health specific measures has the potential to build the evidence base and support research that would fill critical gaps in knowledge. For example, better data would enable the health sector to further understand the prevalence of, disparities in, and challenges associated with perinatal mental health conditions, identify opportunities to create quality improvement initiatives, and foster accountability within the healthcare system. And sixth and finally, enact policies that support families. Untreated maternal depression among people with limited resources may continue the cycle of poverty for both parents and children. Depression can lead to increased absenteeism, reduced productivity, job loss, and challenges returning to work. Additionally, many people feel forced to return back to work in the immediate postpartum period. This is a critical time to support the physical and mental health of the postpartum individual, as well as for breastfeeding, bonding and attachment, adjustments to the demands of parenthood, and development of caregiving skills. Lack of paid family leave during this period negatively affects families' economic security, but more importantly, their physical and mental health. As you listen to the findings that my colleagues present today, we encourage you to consider which of these 6 policy opportunities you will actively work towards implementing. Thank you.
Thank you so much, Jennifer, for that overview and also for all you did to usher the papers through this arduous but rewarding process that we have at Health Affairs. It's now my pleasure to introduce to you Congresswoman Lauren Underwood, who serves the 14th Congressional District in Illinois, was sworn in to the 116th Congress on January 3rd, 2019. She's the first woman, the first person of color, and the first millennial to represent her district in Congress. She's also the youngest African-American woman to serve in the U.S. House of Representatives. But in addition to all of that, she brings great knowledge and experience to this issue. I won't review all of it, but we should note that she has been a senior advisor at the U.S. Department of Health and Human Services. Congresswoman Underwood, take it away.
Well, thank you. Hi, everybody. I'm Lauren Underwood. I have the honor to represent Illinois' 14th Congressional District, and I'm the co-founder and co-chair of the Black Maternal Health Caucus. I am so delighted to be with you for today's event, and I'd like to begin by thanking Alan Weil and the Health Affairs team for inviting me and for your ongoing commitment to informing evidence-based health policy through the high quality research that you publish month after month. And I'd also like to thank Jennifer and her team and everyone, all the researchers who contributed to this special issue on perinatal mental health. Thank you for your work to advance our understanding of this critical topic. The articles in this month's issue underscore just how great the need is for bold action to support people with mental health conditions and substance use disorders during and after pregnancy. Mental health conditions are one of the leading causes of pregnancy-related mortality in the United States. And in my state of Illinois, our 2021 maternal morbidity and mortality report found that mental and behavioral health conditions were the #1 cause of pregnancy-related deaths. So to improve perinatal mental health in our country, we need to act with urgency. And that's why I introduced the Black Maternal Health Momnibus Act of 2021, which builds on existing legislation like expanding postpartum Medicaid coverage for a full year for all pregnant people, with a sweeping set of 12 bills to address every driver of adverse maternal health outcomes and disparities in the United States, including with a specific focus on maternal mental health. Now, one of the bills in the Momnibus is the Moms Matter Act, which was introduced as a bipartisan standalone bill that I co-led with Representatives Lisa Blunt-Rochester of Delaware and John Katko from New York and Brian Fitzpatrick from Pennsylvania. Now, the Moms Matter Act would provide robust funding for programs to support pregnant and postpartum people with mental health conditions and substance use disorders, including initiatives to address stigma, for example, provide culturally appropriate services and support, strengthening suicide prevention programs, and raising awareness about the warning signs for perinatal mental and behavioral health risks. The bill would also provide funding to accredited mental and behavioral health education programs to grow and diversify the perinatal mental health and addiction workforce, addressing the gaps in access to care that we see in too many communities across our country, particularly in communities of color and other underserved areas. Now, I'm thrilled to report that these investments and other critical Momnibus provisions have been included in the Build Back Better Act. Now, for those who have been tracking on the news, you know that that's the same thing as the $3.5 trillion plan that Congress is working on right now. Okay, Build Back Better Act. In addition to funding specifically for perinatal mental health, the Build Back Better Act includes funding to address social determinants of maternal health, resources specifically for community-based organizations, and investments in programs to grow and diversify the perinatal workforce. There's also funding for maternal health research at minority-serving institutions and for health professional schools that are addressing the impacts of climate change-related maternal and infant health risks. These are investments to promote representative community engagement. There are investments to promote representative community engagement in our maternal mortality review committees. We can offer some bias training for healthcare professionals, strengthen our federal maternal health programs at CDC and NIH, and expand access to digital tools that promote maternal health equity. So these are just some critical investments that support mothers and babies and families, and we have to get them signed into law. There have been too many alarming statistics, too many devastating stories of loss to wait another second. So thank you again for having me today. And thank you for the shared commitment to save moms' lives and end the racial and ethnic disparities that we see in maternal health and ensure that in the United States, every family can thrive. Looking forward to our conversation today.
Thank you, Congresswoman. That was such a great change in energy from our staid academic approach to yours. I'll try to channel a little of it myself. It's now my pleasure to welcome Ellen Marie Whalen, Chief Population Health Officer at the Centers for Medicare and Medicaid Services and Senior Advisor to the CMS Innovation Center. Her experience includes time on Capitol Hill in a number of roles, including as staff director to the U.S. Senate Subcommittee on Aging. She's also a fellow of the American Academy of Nursing. Ellen Marie, I'll turn it over to you.
Thank you, Alan. Well, that's certainly a tough act to follow. I'm not sure I'll have that much energy, but I certainly will try. Really excited to be here with you. Thank you for the invitation. Also, a bit of a fangirl. As a recovering health services researcher, I will tell you that Health Affairs is often the journal that we go to in the administration looking for any policy advice, be it the journal or the blog. It is really an important tool for us, so we really appreciate that. In my few minutes here, I'm going to talk about three general areas, and I'm pleased to say some of them are directly related to the policy recommendations Dr. Moore just outlined and some ideas that Representative Underwood just mentioned as well. I'll talk about what we're doing to expand coverage for new moms, what we'll do to ensure once someone is covered, they receive that high quality care, and then I'll touch on a few of our mental health initiatives. First of all, everyone at this event certainly understands that the health of our nation really begins with the health of our children and families. We're committed to improving the health of low-income mothers, reducing pregnancy-related health disparities, and reducing the rate of maternal morbidity and mortality by addressing continuity of care needs for postpartum women. Some people are surprised to learn that Medicaid covers 42% of all births in this country and 65% of African-American births. We also cover 17%, almost 1 in 6, of all non-elderly women nationally. So we understand the critical role that we need to play in addressing maternal health. First, for CMS to be able to help individuals during the perinatal period, they need to be enrolled in one of our programs. And also, Medicaid only requires states to provide postpartum benefits to pregnant individuals for 60 days. As a clinician who's worked with moms and newborns, I can't imagine trying to juggle a newborn and simultaneously trying to find and access new healthcare coverage when my insurance runs out with a 2-month-old. That's why we're so excited that the American Rescue Plan now provides states with this new option to increase access by extending Medicaid postpartum coverage from 60 days to 12 months, a full year. Before this provision, states could only expand postpartum coverage through a Medicaid Section 1115 demonstration waiver. But now, or as of April in 2022, states will have the option of expanding coverage through a much simpler state plan amendment. Some of our states aren't waiting, though. This past April, we approved a demonstration for Illinois, and it became the first state in the nation to extend postpartum benefits for a full 12 months. Additionally, we approved a demonstration for Georgia that extends the beneficiaries to 6 months, and Missouri that extends the benefits to 12 months for women being treated for substance abuse disorder. We're looking forward to working with states to take advantage of this new provision to extend the benefit coverage, strengthening continuity of care, and reducing the rate of maternal morbidity and mortality, especially for communities of color. But you all know that just having coverage is not enough. We have to work to ensure that pregnant individuals and new moms have access to quality coverage, including mental health services. To support CMS's maternal and perinatal health efforts, we have a set of 11 maternity core quality measures that state and Medicaid and CHIP agencies report to CMS. These measures are reviewed annually and in consultation with a broad group of Medicaid and CHIP stakeholders and liaisons to other federal agencies. In addition to the maternity core set, our adult core set includes some other measures related to maternal health, such as breast and cervical cancer screening, hypertension control, and diabetes management. Now, currently, these are just voluntary reporting measures, but in 2024, any of the measures related to children and behavioral health will be mandatory, so all states will be reporting all of those measures to us every year. Another way that we look to improve the quality of care for moms and babies is through our Maternal and Infant Health Initiative, or MIHI. This initiative started 7 years ago, and it's a way to collaborate with states to improve access to the quality of and the care delivered to pregnant and postpartum women and their infants. And this year we identified 3 priority areas: increasing the use and quality of postpartum care visits, increasing the use and quality of well child visits, and decreasing the rates of cesarean section births in low-risk pregnancies. In each of these areas, we'll be developing affinity groups to provide technical assistance, and not just to states, but to their public health agencies and to their state partners. So we're excited to what we will learn in those affinity groups, and in that, we will also then integrate that into future work that we're doing at CMS. And last, I'll move just to a couple of the things that we're doing in the mental health, behavioral health space. First, I want to flag something that we did back in 2016 that may not seem groundbreaking, but I, as a pediatric provider, was thrilled to see. And that's allowing pediatric providers to screen new moms for maternal depression and then bill for those services. Based on recommendations from a whole host of stakeholders, we clarified, since maternal depression screening is also a direct benefit to the child, pediatric clinicians could bill for postpartum depression screening. This was not as straightforward as it might seem, allowing pediatricians to bill for services not directly for their patients, but for their mother, initially raised a few eyebrows. But based on the overwhelming evidence and strong stakeholder response, we were able to get to a yes on this. This provides an opportunity to meet new moms where they are, even if it's at their baby's healthcare appointment. And finally, I'll note a new initiative we're working on to help address the rising crisis of mental health in the community. The American Rescue Plan also created another optional benefit for states to implement and administer community-based mobile crisis intervention services, and allowed for an increase in Medicaid matching rate for these services for the first 3 years starting in April. These are services for anyone, anywhere, and anytime, face-to-face professional and peer intervention deployed in real time to the location of the person in crisis in order to achieve the needed and best outcome for that individuals. To help states develop these services, just last month, we announced $15 million awarded to 20 different state Medicaid agencies as planning grants to support the development of the mobile crisis units in their states and meeting people where they are. All this said, I know we still have a long way to go, but the timing of this special edition of Health Affairs couldn't be better. President Biden has made maternal health a priority. And this work being done is not just at CMS, and it's not just at the Department of Health and Human Services. We are taking a whole of government approach to better understand what more we can and should be doing to improve maternal health and to eliminate disparities. I'll be sharing these papers in this journal widely across the administration, and I really want to thank all of you for the work that you're doing in this space. Thank you so much.
Thank you, Ellen Marie, for that excellent description of what's going on. I want to start with a question. It's probably a little more on the political side, but I hope you'll both take it up, which is, I do feel like there's growing attention in a very good way to the challenges of maternal mortality. But this, as we've noted, our issues focused here on mental health. And I'm curious whether you feel that the mental health aspects of maternal health get the same attention, what it takes to get traction. And I guess I also want to ask, given the nation's ongoing opioid crisis, if when we talk about mental health, people first turn immediately to thinking about substance use, as opposed to the other very important aspects of mental health disorders. I'm just curious, where does the conversation go when we're talking about maternal health?
Well, I can start. So I'll say this. What we know is that culturally, we are all very familiar with what postpartum depression looks like, right? I think that we know what signs to look for in our friends and our sisters and our neighbors and our partners, and it's been well socialized where there might be when there might be a need for intervention. But when we get into anxiety or other more severe mental illness and a substance use disorder, I find that there's not that cultural reference point. People don't know what to do, and there's not the expertise in all of our communities across the country, which means that our pregnant people and postpartum people are lacking the resources locally for where to go to get help. The other aspect of this, Dr. Whalen, that I think that you're hinting at is a lot of the recent funding in the mental health space has been exclusively for substance use disorders. And so what that means is that many communities have plenty of resources for naloxone and plenty of resources for like kind of crisis intervention around overdoses, but may not have the same type of resources for other mental and behavioral health crises. And it's certainly not in the postpartum circumstance. And so that's what makes the Mommy Bus so exciting, is that built into our definitions of both mortality and severe morbidity, we have explicit references to suicide. We have explicit references to overdose and explicit references to the kind of range of mental health related conditions for the full year-long postpartum period, even if we're not seeing, for example, local health providers, right, like the death certificate type pointing back to that pregnancy. Our definitions are broad enough, which opens up those funding streams.
I'll also, that those are really important issues, and thinking about all the ways that we can start to address that. But I'll also note that one of the things that has made us pay that much more attention to what's happening in the mental health space now is COVID, and what has happened as a result of folks not having access to services during COVID, and highlighting the disparities and the disparate access folks have had to it. We've been mining our TMSIS, or our Medicaid data, which is a relatively new data set where we can look across the country at all 56 Medicaid programs and start to look at all sorts of variables, including utilization services. And one of the things we're paying close attention to is we recently posted some analysis of this data that showed from March through October of 2020, Medicaid and CHIP beneficiaries have missed millions of primary, preventive, and mental health services when compared to that same period in 2019. And this includes a 34% decline in the number of mental health and services utilized by children under 19. And we're still digging through this, but I'll just let you know that I think that has shown a light on generally what we are or are not doing, and trying to figure out how we can do a better job looking at addressing mental health issues, and I think also looking for opportunities to integrate them with primary care practices.
Thank you. I want to weave in some audience questions. There was a question in about support for midwifery care, and I'll just leave it broadly at that and let you take it in whatever direction you'd like to go, either one of you.
I can start. Midwives are a required provider under Medicaid, which is great. And we also know that sometimes there are barriers still for getting their services covered. On that note, though, I'll talk about one of the successful models. I also am an advisor over at the CMS Innovation Center. And one of the first models that they did, the Innovation Center, that specifically served Medicaid beneficiaries was the Strong Start for Mothers and Newborns model. It was a 4-year model. We looked at different approaches to enhanced prenatal care with an eye specifically towards reducing prematurity. And of the 3 models, the one that was the most successful was care delivered by midwives in birth centers. And a rigorous evaluation there found that the care delivered by midwives was more than $2,000 less for each mother-infant pair compared to Medicaid beneficiaries with similar characteristics. And in addition to being less expensive, they had significantly lower rates of preterm birth, lower rates of low birth weight, lower rates of C-section, and higher rates of vaginal births after C-sections. So not that we needed more information, but this was a strong model that we did, a strong evaluation, and we are looking for ways to continue to try to promote this for Medicaid beneficiaries across all the different states.
Ellen Marie has outlined just some incredible work that they are doing over at CMS. And I am just so excited about these kind of findings. You know, we love our midwives. We love our nurse midwives. And with the Momnibus and our Perinatal Workforce Act, what we are setting out to do is grow and diversify that perinatal workforce, including midwives, doulas, lactation consultants, right? We believe that every pregnant person in this country should have a choice in provider. It shouldn't be limited to geography, where you live, your proximity to an academic medical center, right? We believe that rural moms should have access to provider choice. And this is something that has touched my congressional district. Even an hour outside of Chicago, I have a county that doesn't have a hospital. And so we don't have the same type of provider diversity, and certainly not the full range of perinatal providers in our community. And that's a problem. And so I'm really excited about this provision as well. And I think that there's going to be some great additional resources, meaning financial resources, to come once the Omnibus gets passed to get more people into this workforce and spread across the country.
Great. I received a question about the role of intimate partner violence in perinatal mental health and the significant interplay between the two. And the questioner asks, is that a dimension of mental health that gets much attention in any of the policies and programs that you all are discussing?
Absolutely. So in the Congress, we have to take things, a little bit, it's segmented a little bit. It's not as integrated as it might be in a clinical practice setting. So we have the Violence Against Women Act, which we are still working to get through the Senate. If you care deeply about this issue, I would urge you to reach out to your senator. It doesn't matter what party they're from. We need the Violence Against Women Act to move. And I would also just note that I have co-sponsored a bill that Congresswoman Gwen Moore is leading out of Wisconsin to explicitly address this issue, the role of intimate partner violence and its intersection with maternal mortality and severe morbidity.
I'll just say it's a critical issue, and I think one that probably we're not paying as much attention to. Look forward to the work that Congress is doing to help us move forward. And I think there's some articles in the paper in this journal that address some of that. And so we'll look forward to seeing what other opportunities we can be moving forward to try to address that.
Great. And then I'll ask one last question also that came in from the audience about quality measurement and reporting. You've mentioned, of course, the dominant role of Medicaid and the reported quality requirements in Medicaid and CHIP, but there's still a lot of people of birthing age and who are in private insurance where those mandates don't apply. What do we do to push a quality agenda and a transparency agenda around perinatal mental health for people who have private health insurance?
Well, I'd say this. We know that the disparities persist, regardless of income or education level, geography, right? That this maternal mortality disparity is something, and severe morbidity due to mental health and behavioral health and substance use is something that continues to be a challenge. And so at the Black Maternal Health Caucus, we have been working with our private payer partners to get access to their data sets. We have been encouraging them to make those data sets public. We love some sunshine and transparency, especially with our private payer data. And we are, really excited about the opportunity with the Mommy Bus to make these investments where it's not explicitly tied to your payer, right? If we can improve and grow this perinatal workforce and increase access to care, and we can make it convenient, easy, and low cost for the birthing people, then we expect to have an opportunity to save lives. We don't want to leave anybody out, regardless of who is paying for their healthcare.
I'll just note it's a really critical issue, and it's an issue. We know that we can't move the needle on so many different issues across CMS unless we involve our private payer partners. I don't know whether folks here know about the work that we do with the Healthcare Payment Learning and Action Network. It's a group of providers that have come together, also other stakeholders, looking at commitments that we can make in all sorts of areas. Many of the commitments have been as we're looking to value-based care, but in that space, we also look to how we can align all sorts of issues, including measures. So we're looking at equity measures, we're looking at measures to look to see if we're doing a better job moving from fee-for-service to value-based care. And with these private payers, as part of this Healthcare Payment Learning and Action Network, or we call the LAN, we have a really wonderful opportunity to be able to look across and make sure that we're working together. So it's not just siloed payers working, which is hard for clinicians as well. But it's also a really good way to make sure that we improve outcomes nationwide.
Hey, Alan,
Yes.
I got the exact name of the bill about the domestic violence. I just wanted to be precise. It's HR 4916, the Protecting Moms from Domestic Violence Act. And so for the viewers that are watching that are interested in supporting, they can reach out to their member of Congress and ask them to co-sponsor that bill.
Great, thank you. Well, Congresswoman Underwood, Dr. Whalen, thank you so much for being a part of this program, for setting the stage on the really interesting and important policy movement. We're now going to move into a Policy Wonk's Delight, which is we're going to hear from authors of 5 of the papers in the issue. And I know you'll find that interesting as well, but I want to thank you both for your leadership on this as well as your participation today. And now I will turn to our paper authors. I'm going to introduce quickly all 6 of the people you'll be hearing from so that I can call on them quickly as we move from paper to paper. These are all presentations of papers that are in the October 2021 issue of Health Affairs. As Dr. Moore noted at the outset, there are quite a few papers that we couldn't fit into this program. We hope you'll read those as well. And then we'll have a limited amount of time for questions after the presentations. If you're watching live, do feel free to send in questions. It will be a little harder for me to weave them in at this point. You'll hear first from David Goodman, team lead for the Maternal Mortality Prevention Team at the CDC's Division of Reproductive Health. Among his extensive experience, he was a founding member of the Georgia Maternal Mortality Review Committee. You'll hear from Clare Brown, assistant professor in the Health Policy and Management Department of the Faye W. Boozman College of Public Health at the University of Arkansas for Medical Sciences, where she serves as co-director of the Master of Science in Healthcare Data Analytics program. You'll hear from Shannon Simonovich, an assistant professor at DePaul University's School of Nursing in Chicago. You'll hear from Jasmine Getrow Moore, a PhD student at the University of North Carolina, Greensburg, and co-founder of RJ Squared, a reproductive justice-centered consulting group. Saida Pepra is a licensed clinical psychologist and a trained birth doula. And both Jasmine and Saida will be presenting on behalf of an interdisciplinary team that developed the paper that they're presenting. And you'll hear from Kara Zivan, professor of psychiatry, obstetrics and gynecology, and health management and policy at the University of Michigan. a research career scientist at the Department of Veteran Affairs and senior health researcher at Mathematica in Ann Arbor, Michigan. Kara will present both as a health services researcher and as the author of this month's Narrative Matters essay. We'll just run through all of you in turn. I'll turn it first to you, Dave.
Thank you, Alan. So maternal mortality review committees are state and local-based multidisciplinary teams that identify and review deaths that occur during pregnancy or within 1 year of the end of pregnancy. The next slide. This report describes the characteristics of pregnancy-related deaths due to mental health conditions, including substance use disorders, and identified opportunities for prevention based on recommendations from 14 state-based maternal mortality review committees for 2008 through 2017. The next slide, please. Among 421 pregnancy-related deaths, 46, or 1 in 9, were due to mental health conditions. For the majority of pregnancy-related mental health deaths, 63%, the manner of death was suicide. Next slide. Pregnancy-related mental health deaths were more likely to occur 43 to 365 days after the end of pregnancy, a percentage larger than observed for deaths from other causes, 63% for mental health deaths versus 18% for deaths from other causes. Pregnancy-related mental health deaths were the leading cause of death in this late postpartum time period. Next slide, please. Pregnancy-related mental health deaths were more likely than deaths from other causes to be determined by a maternal mortality review committee to be preventable. Among pregnancy-related mental health deaths that had a determination of preventability, 100% were determined to be preventable, compared to 64% among deaths from other causes. Next slide. Maternal mortality review committees identified an average of 6 contributing factors per pregnancy-related mental health death that they reviewed. Prevention recommendations addressing these contributing factors can be used to prioritize interventions and to inform strategies that enable screening and assessment, care coordination and transitions of care across providers, and continuation of care through pregnancy and the year postpartum. More specific illustrated examples of maternal mortality review committee recommendations within these topic areas are provided as an appendix to our manuscript. The next slide, please. Maternal mortality review committees make recommendations specific to each death that they review. And we present some of the frequent topics or themes that emerged from their prevention recommendations, as well as examples of the more specific recommendations. These recommendations present specific opportunities that individually may have limited impacts, but together may hold larger opportunities. We're grateful for the opportunity that Health Affairs has provided to share this work with an audience that thinks about how these pieces of solutions may fit together to strengthen opportunities for prevention of pregnancy-related deaths and improve maternal health.
Thank you so much. I'll turn now to Clare Brown.
Hello, my name is Clare Brown, and yes, I'm an assistant professor at the University of Arkansas for Medical Sciences. I also want to highlight that I'm a senior research fellow at the Institute for Medicaid Innovation, where I work with Dr. Jennifer Moore, Caroline Adams, and Karen George on this project. In our project, we took data from the Healthcare Cost and Utilization Project inpatient sample to assess the impact of mental health conditions on outcomes associated with delivery hospitalizations. Next slide, please. We looked at 11 different mental health condition categories. We were able to specifically look into 4 of these categories, including anxiety, depression, bipolar disorder, and trauma or stressor-related disorders, as well as whether an individual had any one of the 11 mental health condition categories. One of the outcomes that we looked at was the cost of the hospitalization delivery. What we found is that for individuals who had at least one mental health condition category out of the 11 categories that we looked at, their hospitalization cost was around $458 more, which was around 9% higher. When we looked at the 4 specific mental health condition categories, we found that the most impactful mental health condition category was for women or individuals who had had a trauma or stressor-related disorder. For individuals who had a trauma or stressor-related disorder, their hospitalization cost was around $825 more, or 16% higher. For the outcomes on this page, as well as for the outcomes that I will provide on the next page, all of the models were adjusted for a host of maternal level characteristics, such as the payer on the delivery, whether the individual had any other clinical comorbidities or substance use disorder, as well as a host of hospital level characteristics, such as the region that the hospital exists in, as well as whether it was a teaching hospital, for example. We additionally looked at length of stay. I don't provide a graphic for that for the sake of time, but essentially we found that for individuals who had a mental health condition, any of the categories that we looked at, their length of stay was around 9 to 11% longer. This was only around 0.3 days longer, but given the relatively short average time that women stay in the hospital for a delivery, this was around an 11% longer length of stay. Next slide, please. Can you go back one slide? Looks like we skipped a slide. So the place that we saw the most substantial differences were in severe maternal morbidity. So severe maternal morbidity is measured with 21 different indicators by the CDC. This includes 15 different diagnosis indicators, which include things such as severe cardiac outcomes or getting a blood clot in the lungs, for example, as well as 6 different procedural indicators, such as whether or not you have mechanical ventilation or needed to have a blood transfusion. So in our study, we found that individuals who had a mental health condition had around 50% higher rates of severe maternal morbidity compared to individuals who did not have who did not have a mental health condition. When we looked at the individual mental health condition categories, we found that individuals who had a trauma or stressor-related condition had around 88% higher rates of severe maternal morbidity. Next slide, please. We additionally looked at our outcomes by payer. In this particular analysis, the most common payers, of course, were private and Medicaid covered deliveries. There are a few women or individuals who have a delivery with Medicare coverage. These sample sizes were relatively small for this, so we were unable to include that in our stratified analyses. But what we found were that women or individuals who had Medicaid as the primary payer, they had higher rates of depressive disorders, bipolar disorders, and trauma or stressor-related disorders. For individuals who had a privately covered delivery, they had higher rates of anxiety disorders. And what we found was that for individuals who had a mental health condition that had Medicaid coverage, the impact of the mental health condition increased their length of stay and cost substantially more than the increase in cost for individuals who had private coverage. However, when we looked at individuals who had private coverage, we found that having a mental health condition further increased their rates of severe maternal morbidity more than for individuals who had Medicaid coverage. Next slide, please. So the largest takeaway from our study is probably the substantial impact of having a trauma or stressor-related disorder. There are safety bundles in place that screen for anxiety and depression and have a whole host of resources available for individuals who screen positive for having anxiety or depression. We suggest that it's probably important to additionally include screening for trauma or stress-related disorders and have a more trauma-informed approach to perinatal health. We additionally think that overall there should be increased recognition and indication on the medical records if an individual has a mental health condition. In our study, the rates of mental health conditions that we identified in the data were substantially lower than what is known in the literature. So this is something that we feel should be more readily recognized and documented in the hospitalization data. And finally, we took the estimated number of deliveries. The data that we use allows us to determine national estimates. So we took the estimated number of deliveries with at least one mental health condition, as well as those with 2 or more mental health conditions, as well as the increased costs associated with those deliveries to determine the total cost. Theoretically, experienced in the United States each year, and we found over $100 million associated in adjusted costs for having mental health conditions at the time of delivery. Next slide, please. I'll be happy to answer questions, of course, during the question and answer session. My email is on this slide. I'll also be happy to receive any questions by email. And I, of course, want to thank my colleagues at IMI, as well as support from the Arkansas Center for Health Disparities. Thank you.
Thank you, Claire. I'll now turn to Shannon Simonovich.
Thank you so much. I'm Dr. Shannon Simonovich of DePaul University School of Nursing in Chicago, Illinois. Today, I'm here to share the results of our meta-analysis of antenatal depression and adverse birth outcomes in U.S. populations from 2010 to 2020. Next slide. Adverse birth outcomes directly contribute to infant mortality. With more than 21,000 infants dying each year, we have one of the highest infant death rates among developed countries. And infant mortality is a clear health disparity, with the mortality rate of Black infants more than twice that of white infants. 21,000 infants lost each year. The lives of their families and communities forever impacted. Our childbearing people and their infants deserve better. This must change in understanding how perinatal mental health, specifically depression during pregnancy, impacts these adverse birth outcomes that lead to infant death is critically important. Our study is the first study to examine U.S.-specific data for depression during pregnancy and adverse birth outcomes from the past 10 years, with the ability to look at subgroups by race. As a meta-analysis, this study summarizes the collective knowledge on depression during pregnancy and birth outcomes in one large pooled analysis representing all of the published data available. Next slide. The results of our study demonstrate that among pregnant people with depression, there is an increased risk of giving birth preterm. There is also an increased risk of having a low birth weight baby. We had adequate data to run a subgroup analysis with studies that specifically sampled African American pregnant people. This subgroup analysis found that pregnant African American people with depression have an even greater risk of giving birth preterm and an even greater risk of having a low birth weight baby. This study unequivocally demonstrates that here in the U.S., depression during pregnancy has contributed to adverse birth outcomes over the past 10 years, and that this relationship is particularly alarming among African American birthing people. Universal screening for depression during pregnancy is needed. The American College of Obstetricians and Gynecologists recommends screening during both pregnancy and the postpartum period. However, universal screening for depression remains scarce across the country. Universal screening also creates an opportunity to provide access to more equitable care to address health disparities in perinatal mental health, ensuring that pregnant Black and African American people receive early assessment, referral, and treatment options at the same rate as pregnant white people. In sum, addressing depression during pregnancy is an essential component to improving birth outcomes and reducing infant mortality. I'd like to take a moment to thank my collaborators on this project. Thank you to Health Affairs for organizing this special issue and facilitating today's briefing. Also, thank you to my home state Congressman, Lauren Underwood, for your leadership and advocacy of perinatal mental health policy here in the U.S. Thank you.
I'm now happy to turn it over to Jasmine Getrow-Moore and Saida Pepra.
My name is Jasmine Getrow-Moore. I am a Black woman, mother, scholar, activist, teaching, living, being, social justice, equity leader, strategist, Black Mamas Matter Alliance collaborator, and also very proud to be here with my dynamic team member, Dr. Saida. Saida?
Yes, good morning or good afternoon, wherever you are. Saida Pepra. I'm also a Black woman, a mother of two daughters, so I think of this issue on a personal level and also, intergenerational. I'm a psychologist with a lot of experience working with families, really trying to mitigate their life issues around working in systems. And so this issue is really close to home in the support of people. I'm a doula and a doula coordinator with the Frontline Doulas in California, also with Black Mamas Matter Alliance, with Black Women Birthing Justice, and a lead trainer in implicit bias for Diversity Uplifts. And one of the things that we really thought about as this team, so our article, Reimagining Perinatal Mental Health and Expansive Vision for Structural Change, was really looking at having this interdisciplinary team, this intergenerational team. All of us, are really aligned to the fact that what's often missing in the conversations about preventing maternal and perinatal disparity is the conceptualization and the focus on mitigating systems and systemic issues, and not just looking at personal issues related to the individual that's experiencing a perinatal mood or anxiety disorder. Some of the issues: historical and personal trauma, unstable, unsafe, and inhumane work environments, structural racism, gender depression in the healthcare system and in society. And basically, overall, a lack of social safety net for birthing families, for the community, and really looking at ways to mitigate that. And so we looked at three particular areas: the people, discriminatory systems, and discriminatory structures. And I'll share with you what we highlighted about the people and the experiences of people. So discriminatory treatment, we know, is lifelong for many people, marginalized folks, for women, for those that are affected in society with social determinants and in various aspects. And having discrimination in childhood and education systems, in the work environment, and then also meeting it in the healthcare system, we know that rooting out discrimination is imperative, and looking at key ways to do this in policy. And so some of the suggestions, and some of which people on this panel are already working on, creating and ensuring that implicit bias training and anti-racism training is essential for the perinatal health workforce, and also diversifying the perinatal health workforce. The other area was people's experience with the discriminatory systems and structures. So thinking about parents, that their relationship status, their gender identity aspects that are not really the focus and the center of healthcare as it has been sort of arranged over the years, and thinking about how to have a more inclusive and conscientious healthcare system for all families that enter perinatal care. And then the last thing is really the coverage of a wider range of care models, particularly those that focus on whole person focused care. We talked about midwives earlier, doulas for sure, in-home lactation consultants, and also supporting community-based organizations that really are doing work to nurture birthing families and birthing people in really culturally considerate ways. And then I'll pass it to Jasmine to talk about structures and systems.
Thanks, Dr. Saida. So we really want to make sure that in our conversation on systems and structures that we are also defining what those two things are, because we tend to conflate those two terms. So for clarity, we want to note that systems are the processes related to healthcare service provision, whereas structures envelope and strategically inculcate these systems. As such, well-meaning practices often consider systems change without considering the structural factors, such as mental health stigma, racism, criminalization of substance abuse in pregnancy and the postpartum period, and the disproportionate impact of surveillance on birthing people's bodies. So systems and structures neglect the integrated biopsychosocial reality of health and well-being, which thus erases spiritual, mental, and emotional aspects of pregnancy, childbirth, and postpartum adjustment for peoples, and particularly as we are centering BIPOC persons, Black, Indigenous persons of color. We offer policy recommendations in alignment with the Momnibus that Representative Underwood spoke about earlier. So for systems, we note that policymakers can respond by universally expanding insurance coverage, such as through Medicaid expansion. We've heard this a few times by our colleagues here on this call, and we are also noting that we can extend the length of pregnancy-related Medicaid coverage beyond 60 days. We know that an example of such a program that offers these types of recommendations that we are pushing forth here that are also supporting perinatal mental health of pregnant and BIPOC birthing people are programs such as Shades of Blue Project that provides comprehensive online and in-person services in BIPOC, Black, Indigenous persons of color communities, developed with and by BIPOC providers. With respect to structures, we are lifting human rights-based approaches to advancing health, which underscore the importance of also considering social and structural determinants of health. Chronic stressors such as worrying about how to keep food on the table and a roof over one's head, how to keep oneself and loved ones safe from interpersonal violence, and how to ensure that the water that we're consuming is clean and safe for us to consume and bathe our children with. We are lifting these issues and stating that policies that provide universal paid leave regardless of the outcome of a pregnancy, as well as universal child care, are critical. Acknowledging and addressing interpersonal community violence and other forms of violence is essential here, and also ensuring environmental protection such as functioning water and sanitation infrastructure are key to supporting a wider view of perinatal mental health. Many of these structures that pose obstacles to perinatal mental well-being are based in policy. We know that policy institutionalized racists thought both directly through these discriminatory instruments, such as housing covenants, and indirectly through discriminatory implementation of seemingly race-neutral policies like the TANF Act, which is Temporary Assistance for Needy Families. So what we're saying here is that policy must be leveraged in dismantling these harmful structures and replacing them with structures that support thriving. So in close, what we offer is that policy change requires equity of voice, as Shades of Blue so very well and so clearly exemplifies in their practice and their work, starting with patient-centered guidance. We are proud to work with Black Mamas Matter Alliance, integral in the development of the Momnibus that we've heard about earlier from Representative Underwood. We know that sustained change means that we continue to center our voices. Thank you to our fellow collaborators on this project. Thank you to Health Affairs, and thank you to our leaders in leading policy, Representative Underwood, as well as that awesome representative from my state of North Carolina, Alma Adams. Thank you.
Thank you, Jasmine and Saida. Let me now turn to Kara Zivin. Kara?
Thank you for the opportunity to speak today as a professor of psychiatry who has dedicated her career to studying how policies affect individuals with mental health conditions, and as someone with lived experience. I aim to connect with audiences not just based on data and statistics, but through language and personal narrative. Next slide. I showed here 2 pictures of my son and me. The first one took place about 10 days after my 9th treatment with electroconvulsive therapy. Even though my mental health had started to improve, I still believed that I did not deserve to have Mother's Day because of my illness. The second one took place earlier this year. I am so proud of the person he has become. Next slide. As I became pregnant 11 years ago, 3 months after I remarried, and I became a stepmother facing a ticking tenure clock. At 34 years old, I had dedicated my adult life to my education and science. I also had a long-standing fear of pregnancy, delivery, and new motherhood. Despite having had success using a low dose of an antidepressant to combat previous experiences with depression and anxiety, despite knowing about the high risk of relapse during pregnancy among those who discontinued treatment, and despite knowing that both my mother and sister had each struggled with their mental health surrounding pregnancy, I sought to have a medication-free pregnancy while submitting research grants in October, December, and February before my due date in March. I made the first 2 submissions, but not the third. A positive pregnancy test in early summer led to severe insomnia before the end of my first trimester. Doubts and fears crept in and my mood darkened. After many tear-filled days, I reached out to my faculty mentor, a psychiatrist, who helped me connect with healthcare providers. Medications and therapies did not stem the tide of my depression, anxiety, and insomnia. I stared down my delivery date from the depth of winter as if looking straight into the barrel of a gun. I asked my mother to come from her home in California to mine in Michigan for my baby shower. She stayed for 3 months. I have not yet read all of the articles in this special issue of Health Affairs, but my eye caught a sentence that said, Those who work in this field often hear new mothers say their babies or families would be better off without them. During my pregnancy, those thoughts ran through my head like a mantra. I had become convinced that if I could just delete myself, my husband, stepson, and son would go on without me. In the fog of illness, I attempted this outcome while still pregnant. 2 days after my overdose, I regained consciousness in the maternity ward and my water broke later that night. I had a vaginal delivery the next morning at 35 weeks and 5 days. My son went to the neonatal intensive care unit and I decompensated, racked with guilt. The next day, they transferred me to the inpatient psychiatric unit with an unknown release date. The uncertainty and lack of information combined with being separated from my family and baby remains the greatest trauma of my life. I can still see in my mind's eye myself as a scared new mother sitting at the public computer on the ward, both trying to submit progress reports on a research grant without disclosing my location, and later seeing pictures of my son's first pediatrician appointment that I could not attend in person. After my hospital release and lack of improved mood, I consented to electroconvulsive therapy. 6 weeks after delivery, the day after my first wedding anniversary, I began treatment as an outpatient. To my good fortune, it worked almost immediately. I risked my reputation and relationship with my loved ones by speaking openly, and yet I knew then, even in the haze of my illness, when discussing the use of a pseudonym during my hospitalization at my own university hospital, that someday I would tell this story. Besides choosing to pivot my research career to focus on perinatal health several years after my illness, I started speaking about my experiences. I recognized my extreme fortune and privilege as I understand that other delivering individuals may not have access to healthcare, paid leave, and other supports I experienced. This special issue of Health Affairs makes several policy recommendations regarding perinatal mental health. I highlight here a few. First, allow mothers and babies to remain together. That I needed to get special permission to visit my son on the NICU, and that I could only see him 1 hour per day when my husband brought him to visit me after his discharge, felt painful and bewildering. I remained alone in a psychiatric ward as a new mother. Other countries seem far ahead of the US on providing mother and baby units. We must address this access gap. Next, we still do not know the full extent of how mental health and substance use conditions affect maternal morbidity and mortality. Maternal mortality review committees and researchers compile data, but the lack of systematically collected information leads to substantial underestimates of the true public health burden. I have often thought that if I had died by suicide during my pregnancy, that fact may have remained hidden. Next, we must expand our understanding of and education about perinatal mental illness beyond postpartum depression. People may not be aware of the nature and range and severity of mental illness during pregnancy and postpartum, including anxiety, insomnia, PTSD, bipolar disorder, and psychosis. This knowledge gap leads individuals and their families experiencing these conditions to become isolated, ill-informed, confused, and unsupported. Finally, we must make it safe for individuals to disclose suicidal feelings. I believed that sharing my suicidality would lead to hospitalization or rehospitalization, and so I remained silent. Some women have suffered far worse fates, including imprisonment and loss of custody for suicidal behaviors during pregnancy and postpartum. We know today that reproductive rights face increased obstacles. We must treat mental disorders, including suicidality and substance use, as medical conditions requiring care and support rather than reasons for punishment. I thank all of the individuals who contributed to this special issue of Health Affairs to this panel for their attention and their advocacy. My statements do not necessarily reflect view of my employers or my funders. A special thank you to Representative Underwood for her tireless efforts on behalf of maternal health. Thank you.
Thank you so much, Kara, for presenting that. I have a lot of questions teed up. We have only so much time. I'm going to run through as many as I can get. and they're going to sort of bounce around to different topics. Let's start with the topic of trauma. Claire, you mentioned the elevated costs associated with it. Saida, you mentioned its prevalence. I wonder if we could just hear a little bit more about the incidence of trauma, what we know about the sources of trauma, given the high profile that plays in the negative outcomes that were reported. Claire or Saida or any others, but if either of you would like to start.
Sure, I'll start. I definitely see, I think two aspects of trauma that are relevant: people's historical trauma, their own personal experience of trauma, and birth trauma. And so, in this conversation around birthing, there's two aspects of the birth trauma, which is both emotional trauma that people often experience, having unexpected things happening in their labor and delivery experience, having unexpected postpartum symptomology, but also then physical trauma, which can happen intended, often unintended by providers, just, the physical pain and challenges that can happen within the birthing. But also there have been obstetrical violence accounts that have been well documented in various, organizations throughout the nation and communities mentioning it. And when I do focus groups with moms that are talking about it, I'm hearing a lot of the personal experience that being moved through the system fast, having such short visits that they can't answer or ask questions, and really not feeling centered in the system, but also feeling undermined, feeling not listened to, experiencing being ignored. And then obviously, there's a battling over birth report, something that people on the listening might be interested in. There was one incident where, a provider was basically sort of hitting a mother as she was pushing, and they were telling her, it's not time to push, the doctor's not here. And so this sort of hitting the legs, it's not time to push, stop pushing, like a physical, what we would consider as assault, somebody putting their hands on a person unintended. And so looking at various aspects, unauthorized and unagreed upon episiotomies, a number of things like that. So that's a long conversation, but definitely some summary.
Thank you. Claire?
Sure. So one suggestion is that individuals who face trauma or stress-related disorders may have increased levels of cortisol levels. There have been several studies that have linked those things together. Something we weren't able to dig into in our study because of sample size issues were how race and ethnicity may ultimately relate to trauma or stress-related disorders, higher cortisol levels, and adverse outcomes. So specifically, if a given population is more likely to experience stressful life events and face multiple barriers to care prior to pregnancy and during pregnancy, they may ultimately have higher rates of these trauma or stress-related disorders, higher cortisol levels, and ultimately worse maternal outcomes. So that's one thing that we kind of suggest may be the case. We couldn't dig into all those numbers for this particular study just simply because of data limitations.
Shannon, you mentioned depression and the role of depression screening. I will say one of the papers in the issue that didn't make it onto the panel today is a really excellent qualitative piece on perceptions of depression screening. Kara, you mentioned pressure for how to answer, and actually one of the questions that came in was someone saying that they felt that they couldn't answer honestly due to family pressure. I see heads doing this. I wonder, given the push towards screening and the sense that that's sort of the intervention that's called for, given these various limitations to that intervention, how should that affect our thinking about how to do depression screening, or whether it should be prioritized, or whether there are alternatives that can get to some of the same factors that don't have these barriers? Open that up to anyone who'd like to weigh in.
Thank you. That's a fantastic question. I encourage everyone to read that paper written by a number of our colleagues from the same team. As a nurse, we know that trust and rapport around any sensitive topic is so important. So I think treating patients with fairness and compassion and building that trust when screening for anything that's a sensitive topic is really important. So I think provider education and also education for any other members of the care team is a really important piece. And then, giving women a sense of the fact that there are resources. I think we can't screen without knowing that there's going to be equitable access to treatment and referrals. When you're asking women about their perinatal mental health, it comes at a high cost. You need to be ready to help. you have to mean it genuinely. So that's my comment.
I'd love to add to that the provider also has to know the consequence of every answer, right? And so Kara had mentioned this, and it's certainly a concern among a lot of women of color that people will refer them to Child Protective Services and, cause, a justification for removing their child. So it's really on the provider, and it's something that I teach people a lot in trainings. You can't do a screening that you don't know what the full, experience will be for the client, no matter what they say. And so if they say, yes, I do want to harm myself. Yes, I have had thoughts of harming my baby. What is your institutional response? And you have to have a plan for that, a very thoughtful one, a very held and conscientious one, a trauma-informed one, one that's centered with the client and cultural competency, and that doesn't criminalize them. Because if you then have, a track that your first response is to call social services, which in most institutions that I have experienced, that is their first reaction. And then the social worker's first response by their efforts is to bring in a team to investigate the safety for the child. Then the mother gets lost in that system. And so just really being mindful.
Well, I had a question for Jasmine that actually this just started to turn the conversation that direction. You made quick reference to criminalization of substance use, increased surveillance. I think those are such important topics. I wanted you to slow down. So I'm going to take the question time to ask you to do that and talk about how those play into the framework that you presented in your paper.
Absolutely. And I will definitely invite Dr. Saida to engage this question as well. But one of the things I think is also important to note is in the last several years, we have been seeing quite a bit of increase in response to substance use, particularly with our opioid crisis that has been going on. I would say that being a child that is, while I living and loving North Carolina, grew up in Washington, D.C. at the height of the crack era. And so some of the response to substance use compared to then during the height of the crack era to now is markedly different. I would say that providers and our society as a whole has learned quite a bit from how we criminalize people who are using substances. But to be totally honest, and what I'm seeing in the last 10 years of the opioid crisis with respect to how providers are engaging patients is that honestly, medical racism has saved a lot of folks from having an issue with opioid addiction who are in the Black, Indigenous, and persons of color community. So I would say that there being more of a thoughtful, I would say empathy that is situated in a patient-centered approach for decriminalizing substance use as part of an ongoing current conversation for support, advocacy, and training is something very new. But while that's still happening, there's still Black birthing peoples who are deeply criminalized for their use. And I'm saying Black birthing peoples, and that also is extended to other persons of color. So with respect to how systems are incorporated when there is knowledge of a minoritized person, and I'm going to use that language when I talk about Black, Indigenous persons of color, when a minoritized person who is a birthing person is utilizing substances, oftentimes the empathy and the inquiry with respect to why, how, and what's happening falls flat and is devoid of human-centered, human rights-based care. So again, while there are approaches for extending care to our white birthing kindred, that care and that thoughtfulness is oftentimes not extended to our minoritized persons without being some other systems involved, thereby breaking up families, which is very much a part of the fabric of how the structure of this society has operated for minoritized people in this country. And with that, I'll go ahead and invite Dr. Saida with respect to clinical understandings of how this might have implications in our communities.
I would can I get there are a couple more questions that I just would really like to get in. And sorry, but this one I want to read because it's rare that I get one that I think I just need to read the words on the virtual page. But it says this: I love how so many of the researchers are using gender neutral language describing impacts on pregnant people. Can anyone speak to research on these topics about health disparities for sexual or gender minorities and or the intersectionality of racialized sexual and gender minorities? I wanted to make sure we got that in the mix because it came in from outside and I thought it was an outstanding question. And I'm so sorry, Say, to have cut you off, but maybe this is one you would like to take or someone else, but anyone?
I can start us off. I'm sure someone else can.
That'd be terrific.
Yeah, I think one of the things that's really important in Black Mamas Matter Alliance, which is a team of Black women-led organizations throughout the U.S., all of us really want to center the birthing people in our communities. And birthing people, not all of them identify as female. And so it has been really important and central to people who are direct service folks, people who are working with the people. So not just systemic and policy where you're writing papers and academic where you're used to terminology, but you're not used to sitting with an individual. But when you work with families and you have queer families in the midst, you very quickly realize that there has to be a shift in language. There has to be a way to include and make sure that they know in messaging and advertisement and marketing and in written articles that we are also including them, that we're not just saying only people who identify as female who are birthing are the people that we're talking to. And of course, in research, as most of us know who are pulling from research, they are often only using that terminology and often only identifying individuals who identify that way, right? And so we do have a gap in research. We have a gap in information and access to know what people in gender diverse and queer community would really like to hear. We do focus groups with birthing people. And if you have a minority group, in any group, you're going to have to find ways to center their voices that will take effort and intentionality and deliberate approaches. And we certainly are lacking that in this nation. And so, that's really a call for opportunity there and why many of us are using the language that we use today.
Thank you. Kara, I want to ask, you made reference to parent and child, and I don't know if you had an opportunity to see, but we have a leading to health piece, which I also have not yet referred to because it's not an empirical piece, it's a journalistic piece about exactly that topic and how it's been approached in the UK. I wonder if you are aware of other models that you think we could learn from to address exactly the topic you raised for us.
So there are two different types of centers, is my understanding. So some are intensive inpatient centers where mothers and babies are made together, but then there are also outpatient centers, again, maybe also similar to a model that we see for substance use treatment, although not necessarily tying those together, but that, you might go 9 to 5 every day, the mother and the baby together. I know there's one of those in Michigan that I once visited a number of years ago. And I think that type of model might be an alternative for, keeping mothers and babies completely separate, which I don't know that serves either one of them, their development or connection or bonding or those types of things. So, and I know that other authors in this issue have focused on this topic, and I really wish I understood why the United States is so far behind other countries. I was really interested to learn that in my research on this, because, that never occurred to me and never was brought up as an option for me when I was struggling earlier in my pregnancy. And I think that could be really helpful.
Dave, I want to turn to you. Some may not be familiar with the Maternal Mortality Review Committees, but they are such an incredible resource for understanding. I wonder if you could just, for those who maybe aren't as familiar, say a word about them, but also they're highly variable around the country. And if you could say something about the characteristics of what makes one of those committees function well and really provide the kind of information that enabled your paper to emerge and what makes them maybe not work so well.
Sure. So I think what's exciting to be able to share is that even since the data was gathered and analyzed for supporting the work that was included in the manuscript. We've come a long way in the US with review committees. So currently there's 50 maternal mortality review committees in the US. There are 47 that are state-based and 3 that are city-based. So that in itself is a big step forward from where we were just a short time ago. And so one of the critical components of review committees is that I think is relevant for our discussions here today is the committee composition itself. And really by multidisciplinary, what we're talking about is multidisciplinary within clinical disciplines, but also in non-clinical, right? And so incorporation of membership of community. And community can be community-based clinical care, but also non-clinical care. Bringing in patient voice. And making sure that the committee itself is representative of the populations that are impacted by the outcome of maternal mortality. And so, again, this is an area where there's been a lot of progress made around review committees. There's still some work to do, but we have a lot of activities going on within CDC, which provides technical assistance to all of these 50 review committees and directly funds 31 maternal mortality review committees currently. So that does give us an ability to support some of that standardization across the review committees.
Thank you. Well, this has been a really rich conversation. I would like to keep it going, but the clock doesn't allow me to do so. As we come to an end, I just want to say a few things. First of all, to reiterate our thanks to the California Healthcare Foundation, the Perigee Fund, and the Zoma Foundation for their support of the issue and this event and everything that made this possible. Thanks to Jennifer Moore for serving as theme advisor and all the other roles that you've played in making this possible. We do have some upcoming events. Not on the list on the screen is the Alliance for Health Policy, actually on October 28th. We'll also be doing an event on perinatal mental health, drawing from some of the work in this issue. So we're very excited that there's a second event that'll have a different set of content in it. Coming up from Health Affairs, Thursday of next week, I'll be speaking with Lois Pace. She's the director of the HHS Office of Global Affairs as part of our Policy Spotlight series. On October 21st, we'll have a journal club with an author who was not on the panel today, Clare who wrote about Medicaid expansion and improvements in perinatal mental health, and we'll go deep into that research. On October 26th, you can learn about the Health Affairs Equity Project from our Equity Director, Dr. Vabren Watts, and there will be more to be announced. Thanks to all of you for your papers, your contribution, for joining us today, for speaking. Thanks to the audience for your excellent questions and your engagement. And with that, we are adjourned.